Prevention Day 2020 as we continue working together to prevent suicide. My name is Ashvini Nath. I'm the manager at the Mental Health Unit, Ministry of Health, and I will be moderating this evening's session. The Ministry of Health, in collaboration with PAHO, has observed this day over the last few years. In 2017, a sensitization session was held with the media on responsible reporting on suicide. In 2018, there was the official launch of the media guidelines for responsible reporting on suicide. And last year, there was a technical consultation on the suicide prevention strategy. This year, 2020, we are commemorating things as a sign of the times virtually with a webinar. And we've decided to open up this webinar to the public and talk about the current situation and what the plan is for the way forward for suicide prevention in Trinidad and Tobago. A recorded version of this webinar will be available to participants. We will have an opportunity for questions and answers following today's presentations, and we would love to hear from you. If you have any questions as we go along during the presentations, please feel free to post them in the chat, and then we will get to them during the question and answer segment. I would like to begin by introducing Dr. Erica Wheeler, the PAHO WHO representative, who will bring us welcome and opening remarks. Dr. Wheeler.
Thank you very much. Dr. Hazel Othello, Director of the Mental Health Unit. Mrs. Ashvini Nath, Manager of the Mental Health Unit. Nice to see you, Ashvini, if only virtually. Ms. Caroline Braffett, Mental Health Planner. Ms. Della Ramcharan, ladies and gentlemen, everybody who is with us this afternoon. It's my distinct pleasure to bring to you greetings on behalf of our Director, Dr. Carissa Etienne, and our Director General, Dr. Tedros Ghebreyesus, during today's webinar in recognition of World Suicide Prevention Day 2020, under the theme this year, Working Together to Prevent Suicide. Data from WHO shows that over 800,000 people die each year due to suicide. This works out to be something like around one person every 40 seconds. And these persons represent only those who have in fact succeeded. But at the same time, there's a large number of people who have attempted but not succeeded in taking their own life. There are indications that for each adult who dies of suicide, there may have been more than 20 other attempts. This is alarming, and it highlights the importance of focusing on suicide prevention, not only today on September 10th, Suicide Prevention Day, but this must be an issue to be addressed all year round. Suicide occurs throughout the lifespan and is the second leading cause of death among 15 to 29-year-olds globally. That in itself is alarming. We know that suicide has a negative effect on families, friends, colleagues, and communities. And with the COVID-19 pandemic, which has caused significant disruption to personal and professional lives across the world, it is expected that more people may be experiencing emotional distress, which highlights even more the need to focus on mental health and psychosocial support during this unprecedented time. The pandemic is causing fear, anxiety, depression, and stress among people of all ages. Social distancing, isolation, and coping with perpetually evolving and changing information about the virus has both triggered and exacerbated existing and pre-existing mental health conditions. Studies in countries affected early in the pandemic, and here we refer in particular to China and South Korea, report the presence of depressive symptoms, anxiety, and stress symptoms that are attributable to the pandemic. In 2016, suicide was recorded as the 18th leading cause of death worldwide, with an annual global rate of 10.5 per 100,000 inhabitants. This is reported last year by WHO. At the same time, here in Trinidad and Tobago, the suicide rate was 12.9 per 100,000. So that is above the global rate that I just mentioned. And Trinidad and Tobago ranks 6th in the region for the highest suicide rates. This is an improvement over previous years, but shows that there's still much more to be done. Suicides are preventable. Much can be done to prevent suicide at individual, community, and national levels. There are measures that we can take to reduce the factors that lead to suicide. This is why PAHO is pleased to continue its close collaboration with the Ministry of Health on strengthening the country's response to preventing suicide. Suicide is a serious public health problem and therefore must be dealt with as such. We know that some of the key risk factors for suicide can be divided into the health system and society, such as barriers to accessing healthcare, easy availability of the means of suicide, inappropriate media reporting, stigma associated with help seeking. But we know at the community and relationship level, there are things that we need to address, such as sense of isolation and lack of social support. And this sense of isolation has been aggravated by the physical distancing measures. But we also know that trauma or abuse, such as domestic violence, can also be a factor in bringing on suicide. And at the individual level, we know, as previously mentioned, that there may be as many as 20 previous suicide attempts before successful suicide. Also, mental health problems, harmful use of alcohol, financial loss, and even chronic pain, and a family history of suicide. So it means that suicide prevention is a collective responsibility. So each and everyone has a role to play. We know there's stigma associated with suicides and the family, as mentioned earlier. The wider community is greatly impacted when one person dies by suicide. I am pleased to see on the agenda that Ms. Della Ramcharan will be sharing her experience. Ms. Ramcharan, if you're listening, I commend you for your courage to speak publicly about your experience. And it's through testimonies like yours that we are able to bring attention to the topic, reduce stigma, and get the commitment of stakeholders to advance work in suicide prevention. In closing, I'm encouraging all of you to play your part in dealing with this important public health issue. I want to reiterate the commitment of PAHO and WHO in its continued support of the government's efforts to increase awareness of suicide and to reduce the incidence of suicide in Trinidad and Tobago. So again, on behalf of PAHO and WHO, I welcome you and thank you for your participation in this webinar. Good afternoon.
Thank you, Dr. for very insightful and motivating. It reminds us why we have to be persistent in our suicide prevention efforts. And we're very grateful for your presence. I understand you have another engagement to attend to. So we're very grateful that you made the time to be with us to bring these remarks. Thank you for your continued support of all of our mental health initiatives.
You're welcome. Thank you.
So now I would like to move on to introducing our first presenter. We're going to have a presentation done by Dr. Tarlene Malcolm, who is the Non-Communicable Diseases and Mental Health Advisor at PAHO. Dr. Malcolm is a mental health champion in her own right, always willing to assist us at the mental health unit and make magic happen. She will be presenting on a regional perspective. Dr. Malcolm.
Thank you so much, Ashwini. Good afternoon, everyone. It is a pleasure to always collaborate with the Ministry of Health, and especially in hosting of this webinar here today. I'm pleased to share with you some of the work being done in the region of the Americas as it relates to suicide prevention. And just to save on bandwidth and to ensure good connectivity throughout the presentation, I'll turn off my camera for now, and then I will turn it on back at the end of the presentation. Are you still seeing the presentation, Ashwini?
Yes, we're seeing it.
Okay, great. So World Suicide Prevention Day, as was previously mentioned by Ashwini and Dr. Wheeler, is recognized on the 10th of September every year since 2003. And while it is important not to wait for a particular day to create awareness of suicide and suicide prevention, having a dedicated day like today helps to mobilize resources and increase attention. So for example, throughout the region and globally, but I could speak specifically to the region of the Americas, in several of the countries today, they're having similar sessions, whether it's a webinar, whether it's a radio talk show, whether it's a Facebook Live. So it creates this opportunity to really mobilize and energize the population to speak to this topic and to bring greater attention to this very important public health issue that is sometimes not approached in the way that it should. But especially now, this year, we find ourselves in this very unexpected and challenging circumstances as we cope with the global COVID-19 pandemic. And this pandemic has likely had an effect on the mental well-being of all of us. But this is normal and it's understandable. But for the past 3 years, we have been using the theme, working together to prevent suicide. It is its way of keeping and emphasizing the importance of collaboration. And this year, more than ever, during this COVID-19, it is crucial for us to work together to prevent suicide. And some of us may need a little extra support, like persons with pre-existing physical and mental health and substance use conditions, the elderly, because especially during this time where they are placed in the high-risk group for COVID-19, and therefore they're encouraged to stay home and stay away in terms of that physical. They have limited physical interaction with family members. Some of these persons may not be able to hug their grandchildren. So you can imagine the emotional distress that this have placed on older persons. Also, people living with disability. Our frontline workers, and when we speak of frontline workers, we're not just mentioning our healthcare workers. We're also thinking about those in the service industry, those in the supermarkets, our police officers, our workers at the gas station. So they're out there on a daily basis throughout this pandemic, providing well-needed service to the population, but they too are experiencing this fear, this anxiety, and in some cases, even stigma because of persons believing that they place family members or community at a greater risk of being exposed to COVID-19. We also have to think about the indigenous communities, the migrants, and also people with or recovering from COVID-19. So we can understand clearly the importance of having that collaboration, or for all of us to work together so that we can reach out to those persons, especially the most vulnerable. That should be a priority for all of us. And when we talk about working together, we are not just speaking about the government ministry, which is sometimes what people tend to associate when you speak about work needs to be done. They always think about what Ministry of Health can do, what Ministry of Social Development can do, what the government can do. But it's important for us not just to think about the government ministries or the NGOs that provide mental health and psychosocial support. We are talking about each and every one of us, our families and friends and neighbors and teachers and faith-based organizations. persons affected by suicidal behavior, we all have a role. Again, when we think about what COVID-19 and the stresses that COVID-19 have put on each and every one, you can understand the vulnerability and the risks that are there for others. So the importance of not just thinking about what the Ministry of Health can do, but also looking at our own role and responsibility. So briefly, allow me to share a few statistics. Dr. Wheeler touched on some of them during her remarks, but just to remind us that the data is showing that close to 800,000 people die each year from suicide. And suicide, as was mentioned, occurs throughout the lifespan. So it is not just young people that are affected. However, suicide is the second leading cause of death among 15 to 29 years old globally. And it accounts for 1.4% of all global death, making it the 18th leading cause of death in 2016. So when we look closer home, when we look within the Americas, we see that the rate in the Americas is 9.25 per 100,000, which is below the global rate, but it's still not something for us to even celebrate. It's an improvement, so we always have to recognize changes and effort, but there is still point to a lot more work that needs to be done. And in this slide, you will see that in the 6 years between 2010 and 2016, the global age standardized suicide rate decreased by 9.8%. So that's excellent. We're seeing a decrease in trend, so that is really good. And we have seen the decreases ranging from 19.6% in the Western Pacific region to 4.2% in the Southeast Asian region. And the only increase in age standardized suicide rates was seen in the region of the Americas, with an increase of 6%. And I just want to pause here for a few seconds, because a lot of time when we speak about statistics, we're using numbers and we are using percentage. But each item of data here represents a life that was lost to suicide, something that is preventable. And there is a lot more that needs to be done globally, in the region of the Americas, and of course, in each and every country. And in this slide, I just want to highlight that globally, the rates of suicide in men continues to be higher than those in women, representing 78% of all deaths by suicide. So this is telling us of the importance of targeted interventions. We have to examine the strategies we are using. We have to really look at how we are reaching the different groups, because we understand in health education, in health promotion, in community outreach activity, there are different strategies for different groups. So we have to, as we move forward in strengthening our suicide prevention program, we really have to look at the strategies that we are using to reach different groups. And Dr. Wheeler mentioned in her presentation some of the risk factors. And it is important for us to consider and to look at these risk factors, because we know that suicide is preventable. So we have to look at what are the root causes that are leading to these cases of persons dying from suicide. And these risk factors, as Dr. Wheeler mentioned earlier, are divided into 3 levels. So we have those at the health systems and society level, we have those at the community level, and we have those at the individual level. And just to mention a few, so we know in terms of barriers to accessing care, we have issues there. We have to look in terms of access to the means for suicide, because there are different means that are used. So how do we limit access to some of these means that are used? Inappropriate media reporting on suicide we know the risk associated there. And again, we have to congratulate the Ministry of Health, Trinidad and Tobago, in the development of their media reporting guidelines. And I'm sure Tarlene will speak to that guidelines and the impact that have been making in the country. We also have to look at stigma associated with the help-seeking behavior. And this barrier also help you to even think about the previous slide where we mentioned that men, the rate among men is higher because men tend not to have that help or health-seeking behavior as much as women. So we really have to see how do we deal with these barriers that exist at this health system and society level. Then we have those at the community level. And again, because of what is happening in terms of COVID-19, we really understand, we know that disaster, war, conflict, and any such situation tend to create that emotional distress on the population. So this COVID-19 is placing a lot of that stressors on the population. We also have to think about our migrant and refugee population because we know by themselves there are stresses. So that stress of trying to assimilate into this different culture, that stress of being away from your home, from the environment that you're used to, and trying to live and assimilate into a new environment in itself is stressful and can lead to persons feeling hopeless, feeling lonely, and may be in need of certain support. We continue in 2020 to have issues relating to discrimination. And we also know another risk factors in terms of trauma and abuse. And there are several risk factors at the individual level. Dr. Wheeler mentioned some of them, but again, when you put COVID-19, so generally we have these risk factors. And when you have an added layer of COVID-19, then you can understand why it is important, especially during this pandemic, for us to increase the awareness, for us to reach out as individuals to each other to lend that listening ear that someone may need. We know of the issues relating to job loss and that financial uncertainty that many persons, many families are facing. But the thing is, what we know is that there are evidence-based interventions that have proven over the years to be effective. And we have those that are universal. And one very important aspect of this is countries having their mental health policy. Because this, having a mental health policy, and again, I want to congratulate the Ministry of Health, Trinidad and Tobago, for having a mental health policy, because it is an indication at the highest level that commitment to deal with mental health. It gives the government, it gives the ministry, it gives the country that direction in which they want to take mental health. So having that mental health policy is a key achievement to really advancing the work that needs to be done in mental health. And of course, if there are other risk factors like harmful use of alcohol, then having policies that reduce the use of alcohol would be critical. Ensuring access to healthcare, restriction on access to means, responsible media reporting, and again, Trinidad have done well here, and raising the awareness about mental health and suicide. Then we have those that are selective. So you have to base certain interventions based on the vulnerable group that you're dealing with. We have to continue to do training of gatekeepers and individuals within communities, because as we mentioned, suicide prevention, suicide awareness is not just about Ministry of Health, it's not just about the government, but it's about us as a community preparing ourselves and being able to respond and provide support. And then we have to look in terms of those community-based support, whether it's the assessment and management of suicidal behavior or the assessment and management of mental health and substance use disorders. So this brings us to the PAHO Plan of Action on Mental Health 2015-2020. So one of the objectives of this plan is to implement suicide prevention programs, and there are two indicators under this. We have one in terms of no increase in the regional suicide rate by 2020 compared to our baseline, which was 2013. And in 2013, the baseline rate was 7.3 per 100,000 population. And in our midterm report, we found that 19 of the 34 countries, and that is countries with available data, had an annual rate lower than the baseline. And again, this is speaking about the region of the Americas. And our target is to reduce to be less than 7.3 per 100,000. The other indicator here is the number of countries that develop and implement national suicide prevention program. And again, I mentioned how important it is to have these programs. So in 2013, we had 6 countries, and based on data in 2015, we had 11 countries, and our target is to have 20 countries by 2020. But similarly, the SDG targets 3.4 that states by 2030 to reduce by 1/3 the premature mortality from NCDs through prevention and treatment, and to promote mental health and well-being. And the indicator for that SDG target is speak to reducing suicide mortality rate. So we have the targets, we have the plan. How do we really move to get countries to implement these recommendations and these interventions? So WHO is currently working on updating the Mental Health Action Plan, which 2013-2020, so it is supposed to end this year. But the move is to update it and align it to the timeline of the 2030 SDG agenda, since there are many of the actions that are yet to be implemented by countries. So several consultations have been conducted virtually to aid in the updating of the plan, and probably some of the participants today in this session may have participated in those consultations. So coming out of those consultations, there were some recommended actions that needed to be added or modified. And just to share, one of the additional options for implementation that was recommended was for countries to employ national suicide prevention strategies and plan that guide governments and key stakeholders to raise public awareness, increase help seeking, and reduce stigma of suicidal thoughts and behavior. And the other option was to implement universal and indicated school-based socio-emotional learning programs and other interventions to train adolescents in their problem-solving and coping skills. And some of the modified options for implementation was to restrict access to the means of and suicide. So we know what are the means that are being used. So it's to have systems in place that are able to reduce access to these means, and to improve responses in the health systems and other sectors to self-harm and suicide, including training of staff, and we said non-specialized health workers, teachers, police, firefighters, all the different persons within the community, so that we are able to increase capacity to assess, manage, follow up, refer, and ensure that persons have support as close as possible to where they are. So there are several resources that are available on PAHO and WHO websites. Many of them are listed here, and you can just go on our website and you will be able to access. Quickly, just to also mention, we have a virtual course on suicide that is available on the PAHO WHO virtual campus. It is free, it's self-directed, and it seeks to strengthen the capacity of primary health care professionals. We also have on our website a special section or tab related to mental health and COVID-19 resources. So here you can find all the resources, technical and communication material, information on webinars, other virtual courses, and other video products that are available. So thank you very much, and I will hand over back to Ashwini.
Thank you very much, Dr. Malcolm, for that very comprehensive presentation, for highlighting the problem globally, regionally, and locally, and for reminding us of the different levels of risk that we need to understand to mitigate against, particularly during this COVID-19 pandemic, and for encouraging us because there's already a plan. So we know what we have to do. Now, I'd like to move on to a very special guest. We have Miss Della Ramcharan with us. Della is a very brave woman who has graciously agreed to share her experience. Della considers herself a simple person who is easily contented. She comes from humble beginnings. She is a branch library assistant attached to the Debe Public Library and is currently pursuing her degree in librarianship. She has obtained a certificate in guidance and counseling from the UE Open Campus. Della has anxiety and depression, so she's well aware of some of the struggles of persons with mental health issues. Her personal experiences with mental health is what makes her passionate in sharing her story and spreading the awareness of mental health to others. Welcome, Della.
Good evening, everyone. Thank you, Ms. Ashwini.
Thank you, Della. You can go ahead. Hi, Della. We don't seem to be hearing you.
Can you hear me?
Yes, hearing you now.
Okay. Right, so we're good.
We're getting some trouble with the audio again.
Hearing now?
Yes, I'm hearing you now.
Okay. Okay, right. So I was saying that suicide is something that it
Della, it seems like we've lost you again.
hearing me?
Yes. Yes.
Okay, sorry about that. I'll just share some of my experiences.
Mm-hmm. I'm not sure why the audio seems to drop after we start hearing you.
Hi, are you hearing me?
Yes. Della? Hi, Della. So I'm wondering if we can work on your audio issues. Do you have the time to stay with us after Carlene's presentation?
Yes, I have the time.
Okay, great. So we will try to work on the audio. And in the meantime, I'm going to introduce our next presenter, Ms. Braffett. Ms. Braffett is the mental health planner at the Ministry of Health's Mental Health Unit, and she's been the project lead on suicide prevention since joining the Mental Health Unit 3 years ago. And she's worked very hard to successfully complete the first ever National Suicide Prevention Strategy 2020 to 2025 in collaboration with key stakeholders. As we said, we need to work together to prevent suicide. Today, she will be presenting on the way forward for suicide prevention in Trinidad and Tobago.
Hi, good afternoon, everyone. Can you hear me clearly now?
Yes, we're hearing you clearly.
And you're seeing the screen clearly, right?
Yes, we can see your screen.
Okay, great. So good afternoon, everyone. Again, my name is Tarlene Malcolm, and I took the opportunity to share that. These are the words and the voice of the great relator. I don't know if we have any Kaiso fans in the house, but as we continue the conversation, suicide prevention is everyone's business, and we all have a part to play, including our entertainment sector. I'm going to move on by sharing today where we are now. In order to know where we are going, we have to understand where we are now. And I know that this information would have been shared previously, but just for you to continue to keep the context in your mind. Our current rate, well, as per 2016, is now at 12.9 per 100,000. And as you can see, the regional and global rates, so when you compare it to our rate right now, it is well above the global rate. So the small island of Trinidad and Tobago. The unit, we took the opportunity to review the reported suicide cases coming out of the Trinidad and Tobago Police Service. Right now, the TTPS, the Crime and Problem Analysis Unit, they collect data on reported suicide cases. And if you look at the numbers over the last 10 years from 2010 to 2019, the numbers remain consistently high. Yes, there have been some dips, and notably in 2018, but this is, as Dr. Malcolm mentioned, this is still not something to celebrate. We still have a lot of work to do in this area. I also have to mention that underreporting is still largely a big issue as we address suicide. We're still not quite sure of the actual numbers because we do understand that there are several reports, that several cases or several lives that are lost that go unreported. From the information that both the TTPS and the CSO, the Statistical Office at the Ministry of Planning, we understand that the most common means of suicide being reported or recorded here in Trinidad and Tobago are ingestion of poisonous substances, as well as hanging. As Dr. Malcolm would have shared, there's a large gender difference in the rates of suicide here in the region. And the region, well, globally, as well, particularly in Trinidad and Tobago, we see numbers. I'm going to show you some numbers after, and you can see the stark difference. The age group, I know this is very important, like she mentioned, suicide deaths happen across the lifespan. However, we noticed that largely the numbers occur between the ages of 15 to 54, which is a really large group. However, if we look closer at the actual pictures of these numbers, we can see that there are specific risk factors within these age groups that predispose persons to this likelihood. We'll get to that in a little while. Because of our wonderful cultural melting pot, ethnic factors do contribute to this suicide picture. I'm going to show you a next slide. I will also show you this. Largely, we will notice over the years that the suicide deaths have been largely overrepresented by persons of East Indian descent. Recently, the TTPS have also added geographic location. What they have done, they've added the divisions that receive reports to their reporting. So now we get to see what parts of what regions of Trinidad and Tobago they record large numbers of suicide deaths. So this is what parts of the report might look like. Oh, this is what part of the report looks like. So we can see the age groups, and when we look at the sex, you can see that there's a ratio of almost 4:1 between men and women. And this is quite consistent with global data. If we look at the ethnic groups, this is largely representative of our ethnic makeup. But unfortunately, we're seeing that most of the deaths occur amongst communities of persons of African descent and East Indian descent. And in particular, we're seeing large numbers of deaths amongst persons of East Indian descent. And this was in 2018. Not sure on my slide. Okay, there we go. Similarly, this is another part of the report that we get out of TTPS. They would have now added the divisions, and you can see for 2018, most of the reports came out of the Southern Division, followed by the Central Division. In 2019, we're seeing that the information remains consistent. If you look at the numbers, we had 92 deaths in 2019, reported cases, sorry, and we're seeing that it continues to be overrepresented by persons of East Indian descent, African descent. And in 2019, again, there are large numbers of reports in the Southern Division. This year, in 2019, we're seeing reports coming out of the Northern Division as well, Central, Southwest, and Eastern. Now, these are just some of the main challenges at the unit, and there are other persons and other organizations involved in kind of looking at the picture of suicide in Trinidad and Tobago. And last year, we would have had a consultation on the draft suicide prevention strategy. And several sectors, I'm talking the education, social sector, we're talking about justice sector, health, even the third sector, we had NGOs represented, faith-based organizations represented. And these are just some of the challenges that we're able to identify right now as we're kind of analyzing and assessing where we are at with suicide prevention. Right now, the deaths continue to remain consistently high. So we understand that we're missing the mark somewhere, and there's still a lot of work to be done. I'm sure some people may have noticed too, there's an increase in the reports of homicide, suicide deaths. And this is more present in the media. However, we can't tell whether or not there's an actual increase in these cases, but there are quite a few number of reports in the media. One of the major challenges with suicide prevention in Trinidad and Tobago right now is the lack of a comprehensive surveillance system. So we understand that the Trinidad and Tobago Police Service collects reports, they collect data, and they also share this information. But a lot of the information that is being collected, we're still not getting the full picture. So there's still other fields that we would like to know. Just as Dr. Malcolm would have mentioned, the suicide prevention is far more successful when the interventions are targeted. So we want to understand, okay, where are these deaths coming from? Who are these persons dying? What are the cluster of risk factors? What are the things that increase the likelihood of someone coming to this conclusion? What parts of the what regions of our country do we need to invest more? So these are the information, these are the kinds of things that we want to understand further so that we can ensure that our strategies are hitting the mark and not missing that mark. We want to understand the different age groups. What are the things happening in these age groups? So that's the kind of information that we want to collect. Are you all hearing me still?
We weren't hearing you for a little while, but now I'm hearing you.
Okay, all right. So the last thing I mentioned was about the surveillance system. What we want to ensure is that in order to develop effective interventions, effective prevention programs, we need to know what the problem is. If we're wasting resources if we are developing things that are missing the mark. So a surveillance system will be able to help us better understand where the deaths are coming from, who are the persons dying, what are the risk factors present in those communities or these areas in Trinidad and Tobago, who are the age groups that are more vulnerable, what are the things that they need, what are the support systems that we need to strengthen. This is the kind of information that we need to gather to be able to develop more effective suicide prevention programs. Underreporting, as I mentioned before, is a large challenge. And of course, with underreporting, we don't get a full picture of the problem. Suicide is still a criminal offense. I'm not sure if everyone knows that, but suicide is a criminal offense. And what that does, it prevents proper reporting. I'm sure that you would know that if someone dies by suicide, unfortunately, the insurance does not cover that. So we know that that's a huge challenge because several people, they want to prevent reporting that it was an actual suicide death because that prevents them from accessing the financial support that they need. So we need to address this issue of the criminalization of suicide. This also prevents help-seeking behaviors. As was mentioned before, there are few targeted interventions. In order for us to meet the mark, to really meet the needs of persons, our interventions need to be targeted. Right now, there is limited and ad hoc efforts in promotion and prevention. So there's several sectors, several organizations that are doing human service in promotion and prevention. And if you would have seen the social media today or been hearing the interviews that are happening on television, but there's more talk about suicide. There's the stigma. We're trying to eat away and dig away at the stigma associated with suicide bit by bit. But there's more conversation, and that is the success of the work of several persons on the ground as well as at the higher level. But this work needs to be comprehensive. We need to share the resources. We need to ensure that the work is consistent and the messages are consistent. There's no, and of course that leads to the next point. There's no clear strategic approach. So while everybody's doing something, we're all not always on the same page. And that sometimes contributes to duplication of efforts. It contributes to missing the mark. Sometimes we're doing something and we're not exactly sure what the impact is. Or we're doing something and we're not sure that it's addressing the desired outcome. So a strategic approach would set the framework for all stakeholders to be on the same page so that we clearly understand what are the targets, what are the expected outcomes, what are the resources that we're going to need so that we can all work together. I don't know if Della could probably share on her experience with this, but sometimes, when someone dies by suicide, there's not enough support for the family, as we understand. The most important risk factor for someone dying by suicide is a previous attempt. We also understand when someone dies by suicide in a family, it impacts the family in a very significant way. They're left to grieve. They themselves may also be at risk of attempting suicide. So we want to ensure that there's sufficient follow-up, that they understand the ins and outs of suicide. They understand how they can support each other, and they can also advocate for their own needs and seek those services that are available to them. So we want to ensure that there is enough follow-up, there's enough support, post-vention protocols for family members when they do lose a loved one to suicide. Health systems response. While our health system is working to protect the lives of those that they have to care for, we understand that there are also gaps and limitations within our health service. So we want to be able to strengthen those gaps. We want to ensure that all health workers feel competent to support someone who comes into a health facility who may be suicidal, who may be contemplating suicide. If someone is warded at a hospital, we want to ensure that they're safe there. that even though they may be in crisis, that while they are at our facilities, that they are safe and that the risk factors of the risks are limited in that space. So we want to ensure that all of our facilities, our workers are sufficiently trained, that they're all on the same page as we work together to prevent suicide, even within our health systems. And we also want to ensure that our health systems can be proactive, working in our communities to reach out to families, reach out to groups in our communities, even before someone contemplates suicide. As we all may know, our country possesses a lot of risk factors for suicide. Some of these include gender-based violence. There's been a lot of talk recently, but we know that our figures as it relates to domestic violence and violence in general is very high. And so that what that does, it predisposes a lot of people to this likelihood. Childhood trauma, alcohol and drug use. There are different cultural beliefs or there's taboo around suicide and around help seeking. You know, some people don't believe that going out and seeking help is beneficial. Some people prefer to keep it hush-hush, you know, you don't talk about these things in the family. You know, so all of these ideas tend to prevent people from seeking help when they need it most. Right now, and particularly in this pandemic, there are lots of people who are being challenged by economic factors, losing their jobs suddenly, not being able to make ends meet, people being retrenched. So these are some of the factors. Knowing that these factors exist, now we're able to develop and model and strategize our approaches to address these needs. Non-suicidal self-injury, also known as self-harm, but with little suicide intent. This is something big that's happening amongst particularly our youth populations in schools. We're hearing more about young people cutting and burning themselves. And while this may not necessarily be a risk factor for suicide, it can increase the likelihood of someone harming themselves so much that they end up dying. So this is something we want to keep on our radar as we are developing our suicide prevention strategy. Now, while there are many challenges, these are just some achievements that we've made thus far. In October, finally, we have now a cabinet-approved national mental health policy, and you'll hear more about this in the coming months as we continue to develop our implementation plan. Now, this policy, one of the policy objectives is suicide prevention, so you'll definitely hear more about that. We have also drafted, as Ashwini would have mentioned, we've also finally completed a suicide prevention strategy, and this too will be launched in the coming months. So you'll get to hear more about that and how we plan to implement the strategy. Promotion and prevention, particularly mental health awareness, is also a policy objective, and we have launched our national campaign, Paint the Town Green. I hope everyone is aware of this campaign. This campaign was launched 2 years ago. And this is where we bring together lots of stakeholders to continue the advocacy, to continue the public discourse, to break that stigma as we continue to increase awareness. And this also includes suicide prevention awareness. As Dr. Malcolm mentioned, we would have launched our national media guidelines, I believe 2 years ago, actually, I can't remember. Our national media guidelines. This is 11 best practices for responsible reporting on suicide. There's sufficient evidence to suggest that the way that reports are done in the newspaper can impact someone who may be at risk of suicide. So what we have done is we would have met with media personnel, stakeholders in media to build this document. And what happens is that when we do at the mental health unit, how it works, we record all of the reports that come in online from local newspaper, news media houses. And we rate each report based on these 11 best practices. So if any of these best practices are violated, they would receive a score. And if this score is over a specific threshold, then we make contact with the news media house just to remind them of the guidelines, to kind of engage them that this is what we kind of expect, and then offer support if we are able to support them in any way to better the reporting. We have also, well, like I mentioned before, this increased public discourse. What happens is that at the Ministry of Health, we receive a lot of requests for lectures, workshops, for us to come into the communities to talk about mental health and suicide prevention. Particularly last year, we got a large number of requests for workplace mental health, including suicide. So we know that over the years, there's a lot more interest in having this conversation in the communities. As you can see some of the images, not only the government offices, but we're also seeing the private sector getting involved in this campaign, so to speak. They themselves are also leading the conversation around suicide prevention and mental health. And of course, what we're seeing now is a lot of multi-stakeholder involvement. So it's not just the health sector leading the conversation, but we're seeing a lot of other groups taking it upon themselves to have a conversation in their own network, in their own spaces. So this is where we are. We understand what are some of the challenges, where we have, what are some of the successes, but this is where we want to go. We want a resilient, well-informed society that exhibits a proactive culture of wellness. So it's not just about stopping the deaths, but we want our society to really own this culture of wellness. So we take care of each other, where we value life. And it is rare for someone to attempt suicide. As was mentioned before, this can't just happen. The mental health unit definitely can't achieve that on our own. We require the assistance of all persons and all sectors. Now, this was shared earlier, so I'm not going to go through this in detail, but the World Health Organization was able to identify the different layers of risk factors. So there are risk factors present in our health systems in society, community and relationships, and on the individual level. And that's why we mean this can't be done by one person. So for example, the government can't reach inside your house to support you, but your family member who may understand how to support you or how to support someone else who may be contemplating suicide, that can be an intervention right there. So if we understand where the risk factors are on all these different levels, we're now able to develop programs, develop interventions, develop prevention programs to be able to address specifically these risk factors. There we go. So this is just a brief overview of the strategy that we will share in the coming months. The Mental Health Unit, the Ministry of Health, in collaboration with a range of stakeholders, would have identified these 4 action areas to begin with. Now, the national strategy, how it's going to be rolled out, is going to be rolled out in 5-year periods. Now, the previous slide shows with you a lot of risk factors and a lot of things that can be done. However, we know that we can't do everything all at once. So we identify these 4 areas that are key right now to build a proper foundation for suicide prevention in Trinidad and Tobago. The first thing is that we need strong, committed governance and coordination. What this means is that we need all the different sectors to stand up and to lead this charge. This cannot be done by the health sector alone, so we need persons who are committed to this fight. And what we also need to do is we need to coordinate all of our efforts. We don't want to be missing the mark, and duplicating resources. We want to work together. So we need a strong governance and coordination mechanism. Secondly, our health systems response. We want to ensure that our health system is able to support the needs of persons and able to aptly address suicide at our health facilities. So addressing the gaps, addressing the limitations at our health systems is key. Thirdly, we're looking at mental health promotion and prevention. As was mentioned, we want to meet people even before they contemplate suicide. But a lot of people, there's, like I mentioned, there's several risk factors that are present right now, particularly with this pandemic. There are lots of people who are in distress. And so we want to ensure that even before people come to that place of crisis, we want to meet them before that. We want to support them before that. And of course, we want to continue the advocacy, continue the health promotion. We want to ensure that they're the right support services. We want to ensure that people understand and are educated around suicide prevention and the part that they play in this process. And then finally, surveillance, which is large. So in order to address the problem, we have to understand the problem. And surveillance will give us the information that we need to be able to strategize suicide prevention. Is my slide sticking? Okay, great. So these are just the objectives of these action areas. So the first action area, governance and coordination. We want to institutionalize suicide prevention for sustainable coordination and implementation. What that means is that we don't want suicide prevention or this strategy to just be shelved if our government changes, or if there's another, or if other political factors come into play. We want to ensure that suicide prevention remains on the table regardless of who's in government. We want to make sure that this is a priority for all governments that move forward and for all sectors. Health systems response to strengthen health systems response to suicide and self-harm, as I mentioned. We want to ensure that throughout the system that this is key and that this is so that there are protocols, there are procedures that are in place that everyone is aware of, from the security guard all the way to the psychiatrist, that everyone has a trauma-informed lens to support persons who walk into our facilities with suicide risk. And not even just those who walk in, but those who are also in our communities. Mental health promotion and prevention to strengthen the capacity of individuals and communities to build resilience. Now, we don't want our communities to simply depend on a health facility to support them. We want within our communities that they all lead the charge of building resilience, that they're able to withstand some of the risk factors, that they're able to withstand the stress that is something that doesn't change with life. We know that with life there is stress, but we want communities to work together to build resilience and to recognize the importance of good health. So it's not just teaching people about the warning signs of suicide, but it's going deeper than that, recognizing that mental health is important, and this is something that I need to be actively working on. And finally, surveillance, to implement comprehensive surveillance across disciplines for suicide and non-suicidal self-injury. So while the TTPS is collecting data, we want our health facilities to be collecting data on suicide. If someone comes into our emergency department with a suicide attempt, we want that to be recorded. So we want to understand, what are the numbers, how many people are coming, who are these people? And in our education system, we understand that there are also these student support services division. They too are going to encounter students who themselves may have attempted or may be self-harming. We want to also be aware of those numbers so that we can create targeted interventions even within our school system. So that's the kind of information, that's the kind of surveillance that we want. And finally, what are the next steps? So we're hoping to launch our strategy in the coming months. And this will talk more about, this will basically spell out what is the vision, what are the targets, and then what are the activities for each action area. We also want to accompany this with an implementation plan. This plan will be consulted on because we've mentioned again that this is not just a Ministry of Health initiative, this is an all our week. This is an everybody initiative. First thing coming out of that implementation plan is a national steering committee. We need leaders who are committed to this fight to lead the implementation of the strategy. And then finally, we want to start working. So I want to thank you all for your attention. And if you have any questions, please feel free to type it in the chat. Thank you.
Thank you very much, Tarlene, for your presentation. I think you did an excellent job at highlighting how challenging it is to prevent suicides, noting how multifactorial it is and how complex it is, but that we have a plan in place and that you have identified what the barriers are, and there have been strides made. So I think those, while there are notable achievements, we want to commend you for taking the lead role in such a difficult challenge in preventing suicide. So now I want to go back to Della. Della, it appears that you had an issue with your Wi-Fi, and now let's try to see if we can hear you.
Hi, can you hear me now?
Yes, we're hearing you.
Okay, just wanted to say hi again, everyone. My name is Della, as mentioned.
Della, we're not hearing you anymore.
Hi, are you hearing me now?
Yes.
Okay. Just wanted to say that I'm happy to be here with everyone this evening. Another thing is that I wanted to talk about some of my experiences with suicide or being suicidal. Um, to share one experience, um, was when I was around 15 or 16. I was going through a really rough patch. I was very stressed out with work, with school and home, and just a lot of things going on at that point in time. And I remember on two different occasions. One time I actually drank shampoo, which did not kill me, as you can see. And another time I got a little braver and I tried Clorox. Now that didn't kill me, which I'm grateful for. I've had other experiences later on in my life where I tried tablets and it just it doesn't, in my experience, trying to commit suicide or being suicidal is something that needs to be taken. You need to take it seriously and you need to get help and you need to reach out when you need help. So don't be shy about it because it's your life and you need to fight for your life, right? My message of hope to persons who are suicidal or persons who may be suicidal is to love yourself, pray if you're religious, pray, seek counseling from either a trusted friend, a guidance officer, the social worker. If you're in mental health clinics, talk to your social worker, talk to your doctor. Don't be shy about it. They are there to help and they do help. Um, don't give up on yourself. Keep fighting for you and your happiness. Remember, you are an individual and you deserve to be alive. You deserve to be here on earth and you deserve your chance to make it make it work, right? Um, Friends, be supportive. Um, Family, be supportive, just be supportive to the person, make them feel like they're needed, encourage them, motivate them that no matter what is going on in this situation at this point in time, there is hope for later. You will get better. If you have mental health issues, you will get better. If you're depressed, you will get better. Once as you make that choice to fight for yourself, you will get better. It's not going to be easy, but you will get better and you will have good days as well as bad days. But the most important thing is that you are fighting to survive and you are fighting for yourself. Another thing I just want to mention is that suicide does not discriminate. It does not discriminate on age, race, color, ethnicity, height, nothing. It does not discriminate. So people need to take that into consideration. It could affect anybody. Anybody could be going through a rough patch. It could be stressful. You just need to take steps to try and deal with your suicidal tendencies or suicidal thoughts or whatever negative thoughts to deal with it in a positive way. It's all about how you deal with it. Thank you, and I hope that I would be able to help. I was able to help someone with my lecture.
Thank you very much, Della, for taking the time and for being so courageous and sharing your own experience and for leaving us with a message of hope. And we are all very glad that you're here and we know that you have purpose in helping so many others. So now I want to take us to the question and answer segment. A question, Ramcharan. But before I do that, I just want to introduce that we also have Dr. Hazel, who's the Director of Mental Health at the Mental Health Unit, Ministry of Health, who is also a panelist. So you can pose your questions to the presenters and also to Dr. Othello, if you wish. So Ms. Danmati Ramlakan, you have a question. Feel free to unmute your mic and share with us what this question is. I also saw a hand raised by Mr. Keston Ali. Are you still with us?
Please repeat the name of the person who had a question.
Danmati Ramlakan.
Okay. The person is unmuted now.
Okay.
Please go ahead.
Hello?
Damati, you can go ahead. Your mic is unmuted. Not hearing.
Maybe you can try typing your question in the chat if you're still there. I'm seeing a comment in the chat from Renee Stilling. She's saying she just completed her degree in social work and she believes that more social workers are needed to be hired because of the issues. The issues are more social. It needs to be promoted more, and there are individuals willing to talk and support individuals. The social workers would be able to work hand in hand with communities. So that's not a question, but a comment, and we received that comment that we do have a lot of issues that are social in nature. I don't know if any of the panelists want to comment on that.
Just a short comment. This is Colleen Prophet again.
Mm-hmm.
I just wanted to let the attendees know as well that the strategy is happening within the context of decentralization. So we understand, yes, Ms. Steeling, that yes, human resources is a very big factor, and that the revision of our HR plan to ensure that we have sufficient HR to address these needs, that is on our radar. So you are right, and it is something that is being worked on as we consider decentralization as well.
Thank you, Colleen.
Just to add to what Carlene mentioned, it goes back to the whole thing of collaboration. So it is ensuring that we're all working together, whether you're a social worker, you're a doctor, you're a nurse, you are whatever your role is within the community, and not necessarily have to be in health, then we really recognize that there is a role to be played.
Thank you, Dr. Malcolm, for that response. I'm seeing Michaela Whitley has an exclamation mark. Do you want to make a comment? Okay, she just left. Sabrina, do you want to make a comment? I'm also seeing an exclamation mark by your name.
Sabrina, mic is unmuted. You can speak if you wish to.
I think she muted it back. Okay, I'm also seeing an exclamation mark by Renee Williams. Renee, do you have a question? Okay, she no longer has it. Damien? Damien? Do you have any questions for any of the panelists? So we have Renee Williams typing in the chat. It was brave of the panelists to share her experience with suicide. Thank you, Renee, and we agree. Thank you very much, Della, for agreeing to share your experience. So I'm going to ask participants. Okay. All right, I'm seeing some questions coming in now. If someone blurts out that they feel to kill themselves, are there any indicators to determine if this person is serious or not? So I'm going to ask Tarlene or Dr. Ocello, can you take that question?
Hi, this is Tarlene, and I hope Dr. Sal can share as well. But from a public health perspective, a guideline that the Ministry of Health would have shared is that we take all talk of suicide seriously. We don't leave it up to ourselves to determine intent, but we take all talk seriously and we follow through with the necessary support. We alert someone or we ask further questions, we engage the individual, but we take all talk about suicide serious.
Thank you, Tarlene. We have another question. How can we support family members left in the wake of a suicide? So again, I'm going to ask Tarlene or Dr. Ocello, can you help us there?
I'm muted.
We're hearing you, Dr. Ocello.
Okay. I was trying to. Yeah. I was fiddling around trying to get myself unmuted, so I didn't get the last question. So I need you to repeat that for me,
Sure.
please.
So we have a question. Someone is asking, how can we support family members left in the wake of a suicide?
Okay. Yeah, that family would have been through immense trauma. Losing a loved one in any circumstances is difficult and painful, and in the event of a suicide, it could be particularly traumatic to families. The most important thing you can do as a friend or as a loved one is to just be there for them, to listen, to support, to assist in any way possible, particularly during the early phases. You may be able to provide a meal or help with chores or, any little activities that can make life a little less difficult for them during that period, so that they basically know that they have your support. Keep your eyes open, be observant, and if there are if you think that they're not coping very well, then by all means ensure that they get some help to deal with that trauma. Sometimes people require, some time with someone with a little more training in terms of counseling skills to help them past that. Well, not past, I'm not sure you ever get past it, but to help them to find a place of peace, a place of being able to move forward with their lives without blaming themselves, without blaming each other as family members, without doing the I should have, I could have, what else, mind games that could only make things more painful and more difficult. So it's really important to just be there and be supportive. I just want to go back to the previous question with respect to what do we do when someone says something that indicates that they want to kill themselves? And I endorse what Carlene said in terms of taking all suicide gestures or words or thoughts or notes or anything of that nature seriously. It's important for us to know that each person can help in terms of being supportive, but each person should not take it upon themselves to play therapist, so to speak, right? Don't go beyond your skill set. If you have the training required to evaluate risk and make a determination in terms of how imminent risk might be and what level of intervention might be needed, then by all means do that. But if you do not possess that training, then be supportive and help that person get to where the level of training that is required is present. Thank you.
Thank you for that, Dr. Zalo. We have another question. Family members who remain may be riddled with guilt and may not even face the death properly. What information is in the public forum for supporting people around? Maybe Dr. Malcolm and Tarlene can tell us what materials may be available in terms of helping persons bereaved by suicide.
Sorry, Ashwini, can you repeat the question? I missed it.
Sure. Family members who remain may be riddled with guilt and may not even face the death properly. What information is in the public forum for supporting people around? So I'm saying there may be materials for persons bereaved by suicide that PAHO has, Ministry of Health as well. So
a lot of the materials that we have is that PAHO or WHO has it on our website. But what would be important is to be able to have those materials well packaged and available rather than sending persons directly to the website where they would need to navigate the website to be able to find this information. So again, one of the good recommendation would be to reach out to persons within the communities. So whether it's your primary healthcare facilities there, other NGOs within the community, and then PAHO will be able to provide the information to these agencies that would be better able to provide a package, you know, if it's literature materials or the services that they may need, because they may also need to get certain type of psychosocial support. So they may need to speak to somebody as well. So it may not necessarily just be materials that they will read. So they too will need that level of support from someone. Whether, yeah.
Absolutely.
I don't know if Dr. Othello wants to add to that.
Thanks, Tarlene. I'm not sure if we have anything already prepared, but I'm sure that's a resource that we would be more than happy to avail ourselves of in terms of getting those documents printed in a packaged format so that we can make them available where needed.
Thank you. And thank you for your question, Ms. Hussain Mulun. Now I'm going to ask, there's another question. Does the Ministry of Health have the personnel to meet the challenges of many clients who are prone to suicide and suicidal ideation? Dr. Othello.
Okay, I think I got this question yesterday on the press conference as well. The mental health unit in the Ministry of Health does not provide mental health services in terms of person-to-person communication for the purpose of counseling and providing that level of support. We do the policy direction and we assist the regional health authorities in any way that we can. But it is the mental health services that are delivered through the regional health authorities. That is where the help is needed. That's where the help is available. So, and within the RHs, we have what we call multidisciplinary teams. So we're talking about teams where there are psychiatrists, there are other doctors at various levels in their professional training. There are nurses who have been trained specifically in mental health. There are psychologists, there are social workers, there are occupational therapists, and, you know, they all work together in the best interest of the patient who needs the care, so that once somebody makes contact with the services, they tend to be directed to where the services that they need, to the person who can provide the services that they need. So that's where the help is available. In terms of whether we have enough, we always want more. You know, we never say no. But, you know, we have to be realistic about the fact that governments work with finite budgets. And, well, I shouldn't say finite, but limited budgets that have to do a wide range of things. so that we have to make the best use of the budgets available to us for mental health, particularly the human resource budget. We're always glad for more, but I think with what we have, we try our best to do to do as much as we can so that we could meet those needs.
Yes. We have a comment. Just a reminder to reinforce self-care as the first point of call and accessing primary care for initial mental health needs. So I don't know if anybody wants to comment further on that, but this is from Damien.
Mm-hmm. That's a very important point to make, and thanks for reminding us, because a lot of time we tend not to focus on ourselves, on the ones who are providing the service. So yes, the self-care is critical, and while we are all in the same environment, we are all exposed to the same risk factors. So of course we are also prone, and we have to ensure that we too reach out to others when we're feeling vulnerable, when we're feeling low in our emotions. And as you mentioned about primary healthcare being the first level of contact, and that is very critical again, because one aspect of PAHO, one of the training that PAHO has is the MH gap, which is to build capacity at the first level of care, non-mental health persons, to be able to do these assessments, to be able to detect when they're, by asking the right question, when they're seeing a patient, and be able to then refer the person if that person is in need of specialized care. So thanks to that person for putting that forward.
Okay, more comments from Della. She's saying, hats off to all mental health personnel, social workers, and guidance counselors. We appreciate you all. And thank you for that acknowledgement. You know that mental health professionals are working very hard, and it's good to be appreciated. And if there are no further questions,
seeing a question. That is asking, do you have any support groups or programs for primary or secondary schools that we can be a part of to contribute to awareness? So I'll take one part of that, and then probably Dr. Othello or Tarlene can speak to any in terms of support group. But from PAHO perspective, there is a program called the Mental Health Literacies in School, which aim to build capacity among teachers, administrators, and other workers within the school environment to give them some level of skills and awareness to be able to identify when there are certain warning signs and what needs to be done. So before COVID, this was a face-to-face training, but since COVID, we have been able to create a virtual course that is tutor-led. It was first done, just completed, I think a couple of weeks ago, in Jamaica. So I think the possibilities there for a similar training, a similar course to be undertaken here in Trinidad and Tobago. So Dr. Othello or Tarlene, if you want to speak to what is being done locally.
All right, so I mean, to be transparent, we understand that this too is a gap, but this also has to happen in collaboration with the Ministry of Education. Recently, we would have engaged the Ministry of Education, discussing within the context of COVID-19 how we plan to approach the mental health needs of our students. And the Ministry of Education actually has a full program built out to address these needs. So for schools or teachers who may be interested in kind of engaging in mental health awareness, I think it would be really good to reach out to the School Student Support Services Division to kind of understand where, what they already have planned and where you all can be a part of this. Also, as I mentioned too, annually we have our Paint the Town Green campaign, and we tend to engage several stakeholders, including education. So primary schools and secondary schools can definitely be a part of that program, and you can make it fun with your students. It's an opportunity to teach them, and it's an opportunity to advocate. So they can dress in green, or they can, decorate the classrooms in green. You can have, conversations with your students. So that is also something that you can do, and we can support that as well. So this is just a couple of things that we have. Definitely the mental health literacy program that Dr. Malcolm mentioned is something that we would like to see done in the education sector. So that's what we have so far. I don't know if Dr. Fano has anything coming to her mind, but right now that's what we have so far.
Okay.
I think that collaboration with the Ministry of Education is critical, because they are the main drivers when it comes to the children within the education system. And they've been doing quite a lot. They've shared some of the material that they have prepared for students with us. And since COVID, they're doing a lot of their engagement. They're doing a lot of their engagement, of course, now via digital means. But they informed us that they also have systems in place for children who need things like home visits and so on. So even though most things have gone digital, they are keeping mechanisms open for the children who need that face-to-face contact in order to receive the level of support that they need. They're also engaging with parents as well to make sure that, all those links are in place, so that in the question that they said, the person asked about being a part and contributing and so on, so that I think the most effective way to do that would be to collaborate with the folks at the Ministry of Education. And if you wish for assistance from the Ministry of Health in terms of connecting you with the schools, the Ministry of Education, we can always link you up with the Ministry of Education representative who sits on our MHPSS, that's our Mental Health and Psychosocial Support Network. So you can email us offline, mental.health@health.gov.tt, and we can introduce you to the two representatives from the Ministry of Health, so that you can share with them what expertise or what area of interest you bring to the table, and find out how you can assist.
Okay, thank you very much, Dr. Osello. I think we're running out of time. So I'm going to ask Dr. Malcolm to bring us closing remarks.
Thank you again, Ashwini. Dr. Claudina Caetano was supposed to be with us to do the closing remarks, but she sent her apology because as the regional advisor for mental health, and today being Suicide Prevention Day, she's in demand because many of the countries are having similar sessions like this. So her participation here, she was able to join initially, but have not been able to make it back for the closing. So first, I just want to thank the Ministry of Health for the continued leadership for the strengthening of mental health and psychosocial support program in Trinidad and Tobago. And as mentioned throughout the presentation with Tarlene, much has been achieved, but we know and accept that much more needs to be done. I think another great achievement, and Dr. Othello just mentioned it, is the establishment of the Mental Health and Psychosocial Support Technical Working Group, which is basically there to bring together the different stakeholders that are providing the mental health and psychosocial services in an effort to strengthen coordination. And by strengthening the coordination, it gives all parties, all stakeholders, the ability to see who is doing what, and therefore in a better position to identify areas of gaps. So I must congratulate the Ministry of Health for establishing that network, which is something that other countries in the region are working on establishing. I also want to thank Della again for your courage and willingness to share your experience and the encouragement that you offer to others, for persons to understand that we all go through this difficult time, and it's important to reach out to families, reach out to friends. And the key takeaway message that from this webinar and that we have to remember is that suicide is preventable and that we all have a role to play. So as I said, reach out to someone, offer that listening ear, and support one another. And as was mentioned earlier, the whole self-care is also important, because we also have to assess ourselves, know when we're feeling, when we really need someone to speak to. But in closing, I just want to mention the WHO Live Life guide. This is a document that is being developed. It aims to guide countries to implement key effective evidence-based strategies for suicide prevention. So the focus of this approach is to emphasize the scale-up of 4 key evidence-based suicide prevention strategies. 1, the restriction in terms of access to the means of suicide. 2, the responsible media reporting to support help seeking and to prevent copycat suicide. 3, the socio-emotional life skills training in adolescents. And 4, the identification and management of suicidal behaviors in healthcare settings. So again, we acknowledge the efforts being made by the Ministry of Health and all stakeholders, but it is important for us to just continue collaborating to increase awareness and to support each other, and as we work together to reduce suicide in Trinidad and Tobago and regionally. So thank you again. Have a great afternoon. Thank you for joining us, and I will hand back over to Ashvi.
Thank you very much, Dr. Malcolm, for your closing remarks on such short notice. And I just want to thank all of the panelists once again, the presenters. Della, thank you so much for sharing with us, and thank you participants for making this webinar what it was. So thank you very much for your participation. We hope that this was a meaningful experience for you and that you would have learned something that you probably didn't know before in terms of what is happening for suicide prevention in Trinidad and Tobago. Thank you and have a good evening.